Hello friends, welcome to Knowledge Bites. Friends, today I'm going to teach you an important topic of subject ENT. The topic is chronic suppurative otitis media. Chronic suppurative otitis media. This chronic suppurative otitis media is now known as chronic otitis media. Friends, before continuing this chapter further, I recommend you that please look upon my lecture on acute suppurative otitis media. After that you come to this chapter. So now continuing with chronic suppurative otitis media, let's start. The ASOM, that is acute suppurative otitis media, here if tympanic membrane ruptures, the tympanic membrane gets healed by itself in between 6 to 12 weeks. But if the perforation persists for more than 12 weeks, then permanent perforation will occur. When the perforation is for more than 12 weeks, then permanent perforation will occur, and then ASOM will now be get converted into CSOM. Therefore, in chronic suppurative otitis media, permanent perforation of tympanic membrane occur. Okay. Now, what is the most common cause? What is the most common bacteria involved in CSOM? The most common bacteria involved in CSOM is Pseudomonas. Other bacteria involved in CSOM is Staph aureus, Proteus, E. coli. All these bacteria, they are aerobic bacteroids. This bacteria which is causing CSOM, it is anaerobic bacteria. Now CSOM is of two types: tubotympanic type and atticoantral type. Tubotympanic type and atticoantral type. Atticoantral type is dangerous. It is dangerous CSOM. In this video, we will only get to know about tubotympanic type of CSOM. In next video, you will get to know about the atticoantral type of CSOM. So before making you understand about tubotympanic type, firstly I have to make the diagram on tympanic membrane. I am drawing the tympanic membrane. I am not very much good in making drawing, so sorry for that. This part is known as pars flaccida and this part is known as pars tensa. Suppose somewhere here has occurred the rupture of tympanic membrane. Here is the permanent perforation of the tympanic membrane. So what are the properties of the perforation which has occurred in tubotympanic type of CSOM? The properties are, they are the permanent perforation, the perforation has occurred in the pars tensa, and the perforation is not marginal. You can see the margins are not involved. It is somewhere in center. You can see that the center is involved, but the margins are not involved. Now what are the clinical features of tubotympanic type of CSOM? Suppose a patient comes to you, he gives you the history of he is not able to hear properly and ear discharge is coming out from it. The question which you will ask to the patient to diagnose whether the patient is suffering from tubotympanic type of CSOM or aticoantral type of CSOM. So let me write down. The patient is giving the history of hearing loss, and also the patient tells that discharge is coming. The question you will ask, the discharge which is coming, uh, is it doing pain or not? Then the patient will say the discharge which is coming does not create any pain. So the discharge is creating painless, the painless discharge is coming. And the property of discharge you will ask, the patient will say it is mucoid or mucopurulent discharge is coming. And you will ask the patient, does your discharge smell or not? The patient will say that my discharge does not give any offensive smell. So the property of discharge is, another property of discharge is non-offensive smell, non-offensive odor of discharge. Then you can tell the patient, or you can diagnose that the CSOM to the patient is tubotympanic type, because non-offensive odor of discharge is occurring, and he will also give you the history that it is the recent damage, it's not the old damage. Okay, the hearing loss is because since tympanic membrane is ruptured. Also sometimes it may happen that the ear ossicles getting necrosed. So the most common ear ossicle getting necrosed, the most common ear ossicle getting necrosed is long process of incus. Long process of incus. In tubotympanic type of CSOM, bony wall of middle ear erosion does not occur. No erosion of bony wall of middle ear. In aticoantral type of CSOM, erosion of bony wall of middle ear occur because of infection. So the discharge which is coming is having offensive odor in aticoantral type of CSOM. Now we have to manage the patient. We have to give the treatment to the patient. So the treatment which we are giving, firstly we have to give the medical management, and then we have to give the surgical management. And the surgical management is the definitive treatment of choice. But before performing the surgical management, we have to do the medical management. So what are the things which we are doing in medical management? In medical management, we are cleaning the ear. So we are doing ear toileting. We are cleaning the ear. We are giving local and systemic antibiotics to fight with the infection. Suppose if the ear is dry for more than 6 weeks without antibiotics, when ear is dry for more than 6 weeks without antibiotics, then we can do the surgical repair. Now talking about surgical repair, in surgical repair we have to do myringoplasty. And if ear ossicle get necrosed, then we have to do ossiculoplasty. Ossiculoplasty is done first, then we have to do myringoplasty. Firstly we will talk about ossiculoplasty. In ossicular plastic, we use prosthetic implants, and the prosthetic implants can be TORP or it can be PORP. The full form of TORP is Total Ossicular Replacement Prosthesis, and the full form of PORP is Partial Ossicular Replacement Prosthesis. The use of these prostheses depends upon the absence of the ear ossicles. So the use of this ear ossicles you will get to know after this classification. The classification is known as Austin classification. Austin classification. From this classification you will be able to know which prosthetic implants we can use. Can we use TORP or can we use PORP? So I'm going to tell you about the Austin classification. In Austin classification, we have to assume that incus is absent in all cases. Incus absent in all cases. There are four types: type A, type B, type C, and type D. In type A, malleus is present, steps is present. In type B, malleus is present, step is absent. In type C, malleus is absent and step is present. And in type D, malleus is also absent and steps is also absent. Since malleus is absent and steps is also absent, then in this case we have to use TORP, that is Total Ossicular Replacement Prosthesis. In type C, malleus is absent but steps is present, so we can use PORP. In type B, malleus is present and step is absent, we have to use TORP. In type A, malleus is present and step is present, we have to use PORP. Remember, incus is absent in all cases. You will better understand this when I will explain you where we are placing TORP and where we are placing PORP. TORP is placed between tympanic membrane or malleus handle and steps foot plate. And PORP is kept between tympanic membrane and steps foot plate. You can remember this PORP in type A and type C. We are using PORP. In both these cases, steps are present, and we are using TORP in type B and type D. Here steps is absent in both cases. Now we will see about the myringoplasty. I have done one mistake here. It should not be steps foot plate, it should be steps head. Now continuing with myringoplasty. I have told you we have to do surgical repair when ear is dry for more than 6 weeks without antibiotic. Then only we can do the surgical repair. And the surgical repair we are doing, we have to use the microscope. And the microscope which we are using, it should have focal length of in between 200 to 250 millimeter. Since tympanic membrane is perforated, so we have to put a graft over it, and the graft which we are using, they are temporalis fascia graft. Mostly temporalis fascia graft is used. Mostly we can use other grafts also of some places, but mostly temporalis fascia graft is used. And the graft is placed, there is a technique of placing the graft, and the technique is of two types, that is the overlay and second technique is underlay. So in this video we have completed the tubotympanic type of CSOM. In next video we will continue with the aticoantral type of CSOM. Thank you.